Thanks for the invite. Always a pleasure to be near Sabarmati. You see, the level of evidence goes by like this. In mathematics, it is 1A, physics, chemistry, biology, the medicine that we practice, social science and philosophy. It goes down to 2D. And anatomy, physiology, biochemistry, medical, and prevention actually has the least evidence related to that. So I have the freedom of divulging into something which I feel is right. Pardon me for that, but I feel the message will be loud and clear that we need to prevent. We all know that, but we'll know some guidelines related to that. Of course, preventive cardiology is a proactive, patient-centered, in which the clinician, team of clinician, non-clinician, assess the cardiovascular risks and implements a comprehensive strategy of risk mitigation to prevent cardiovascular disease and its clinical consequence. That means we have to first assess the risk, which is so difficult in India. There are no scores at all which we monitor really. I feel the QRISK-3 score, which is really a British score, it has a lot of Indian patients were involved in managing the score. If at all you want to use, I never use a risk score at all. So it's interesting to see how the transition of cardiovascular mortality takes place with affluence of the countries. For example, in African countries today, there will be famine and pestilence. That means 10% deaths in cardiovascular disease, that too lot of rheumatic hearts. And the remaining are infections and Chagas disease and things like that. This is what kills the patient with cardiac patients. The second step is where maybe some Middle East countries, maybe Pakistan, they are the countries where you 10 to 30% deaths due to cardiovascular disease, and they die of increased salt in the food. There is no awareness. The hypertensions are not diagnosed, and they die of intracranial hemorrhages. And of course, the residual infective things continue. Whereas the third one, where India is today, is degenerative and man-made disease. 30 to 60% of the CVD deaths are due to lifestyle diseases like what we know, diabetes, blood pressure, and maybe atherosclerosis. Europe is here, delayed degenerative, below 50% cardiovascular disease. Their community awareness, they did a lot of work towards prevention, and that's why they have moved into reduced smoking, cardiac diet, regular weight, and that's why their deaths are due to old age disease, Parkinson's and dementia and stuff like that. And fifth is where the USA is today probably. We've gone through all this, and now there is social appeal, mass shooting, and bombing. This is what takes place there. So we are here, and we should now know that we must attack the lifestyle diseases with a lot of science involved in it, but a lot of thought process involved in it. And look at the achievements in public health in the 20th century. It's only up to 2000. Beyond that, graph will still go down. Total cardiovascular diseases after about 1960 or so started going down. Disease of the heart going down. Coronary artery disease going on, strokes going down, and this is somewhere where the statins came onto the scene. And of course, social awareness, smoking and all this thing happened in United States. So a new medical graduate today in USA doesn't want to be an angioplasty doctor. He wants to be a CRT express, electrophysiologist, because that is where the market is. So coronary artery disease going down. I hope this happens to India because it's such a phenomenal change that it saves a lot of health expenditure, and India can save a lot of money and spend it on ISRO. So where is India today? India, urban is here, and affluence, urbanization, education is on the x-axis, and all these hypertension, lipids, diabetes are on the y-axis. So as affluence, urbanization, and education goes on increasing, all these things go on increasing, then the countries form a summit, and then start going down, like what has happened to Europe, North America, Australia, and New Zealand. India is on the upswing. Maybe in the next 20-25 years, we'll have a lot of cardiovascular disease, and then hopefully we'll start going down. My idea is today, for our own sake, our individual sake, our families, our social group, our WhatsApp group, can we start the downward journey on our own? It's possible. Maybe the entire society may not happen, but every doctor can represent a role model of health, and then start working on this, and it will result into a downward journey from here. Another important factor here, see, Russia was merrily going along with these four countries, but suddenly in 1993, Gorbachev happened to Russia. and suddenly you can see that it's gone up. So that means social stability also matters a lot, and that's why it is important to have a very stable government and other things. So chronic stable is a hard atheroma, you all know very well. Suppose this atheroma was not to be formed, is called primary prevention. Second is where it forms a thrombus where it breaks, forms acute coronary syndrome with lot of platelets and a few red blood cells. And it completely forms a red blood plug, that is a myocardial infarction. So the basic thing is a chronic atheroma which breaks and finally leads to events. So preventive strategies would be a major change in small community versus minor change in major community. For example, you do 300 angioplasties in a year, it is a major change in a small community. But you reduce the incidence of smoking in Ahmedabad by 2%. It will save you 500 angioplasties. So that's why preventive strategies are like that. Introduce a small change in the community and you will find the results, whether it is diet, whether it is exercise, whether it is all the talks that we go on, smoking and other things. So there is primordial prevention, primary prevention and secondary prevention. So I would say that suppose you want to alter the genes and the person is born with a smaller risk, is called primordial prevention. Suppose somebody is born with some genes, prevent formation of atherosclerosis is primary prevention. Suppose somebody has atherosclerosis today, preventing ASCV event is the secondary prevention. This is my own strategy of preventing recurrent events would be tertiary prevention. So all these 4 types of preventions are possible and we'll just delve into them in the next 20 minutes. So primordial prevention, actually what is to be done is genetic mix. The Indian strategy of marrying in the same gotra and all is not correct. In fact, there are Indian communities where they absolute no for the same gotra. So that's a correct scientific strategy. And that's why we should be avoiding, rather encouraging intercaste marriages and other things, because that will lead into genetic mix. Lifestyle has a little role to play here because a person is not to be born with a disease. So it's only those who have family history should be careful, like in marriage's time, you can ask the history if there is arranged marriage and things like that. My surgeon friend from Pune, his son got married to a Japanese girl, Shoko. So this is really genetic mix, and I'm sure the genetic mix brings down the overall atherosclerotic incidence in this in their next families, next generation. So this is a 38-year-old man who's undergone a bypass surgery. You can see the oxygen line here, and see the dense arcus juvenalis in it. This is arcus juvenalis, which means his LDL levels were 260, and this kind of a patient were in a rapid progressive aggressive atherosclerosis, premature atherosclerosis. And one Yemenis girl was sent to us for aortic stenosis, but actually her problem was a autosomal type of a hyperlipidemia. All these xanthelasmas over there, tuberous xanthomas and xanthomas here. And actually her aortic stenosis was also related to this deposition of cholesterol in her aortic valve. So a lot of controversy related. She was 9 years old. I sent her back to Yemen. I didn't treat her aortic stenosis also. I'm controversial, but okay. So the metabolic and diabetic related risks that we have, I call this central obesity as a metabolic sin, not as metabolic syndrome. See here, it is a metabolic sin because you can prevent it from the beginning, and if at all you have it, probably you can control it as time goes by. So these waist circumferences, and you know them very well, but metabolic syndrome not only increases the atherosclerotic risk, but can also lead to multi-organ system dysfunction. It's not the bad looking paunch, but it is a fat which gets deposited on the pancreas, leads to a less powerful or less quality insulin and triglycerides and other things that follow with it. There is a concept of thrifty gene. This is by Dr. Yajnik from Pune. What he says is, or Barter's hypothesis maybe, a child is born underweight because of various reasons, and the grandma thinks that this should be fed well and let him be normal boy at the time when he goes to school. So an underweight boy is fed so well that at the end of age of 5, when he goes to school, he is probably a little obese. And the thrifty gene that has inside cannot handle this overfeeding in the early ages. And that finally leads to metabolic syndrome, early diabetes and other things. So that can also be prevented. It's a very simple thing to remember. So let's come to now from primordial prevention come to preventing atherosclerosis, that in formation of atheroma plug. This is by maintaining targets of risk factor like diabetes, weight, blood pressure, high LDL cholesterol. It's also related to lifestyle change, because lifestyle change will make a difference here. Generally, a 75-year-old comes who's triple vessel calcific disease, and the family asks me, what is the dietary control that we should offer? I said, you in the 40s, you go for dietary control. Let him eat very merrily, or at least don't be so strict about his diet. Statin and aspirin only in special cases. Aspirin is not to be used for primary prevention in ladies. And statin, aspirin in primary prevention in men also in very select high-risk patients, not otherwise. So aspirin, which was a bane of everything initially, now is slowly waned off, and now it is to be used. The statin becomes even a drug for primary prevention. So whether it is diabetes, tobacco, all these other factors you know very well, but I want to bring to you some other risk factors like vitamin B12 or homocysteine deficiency, vitamin D, LP little a, pollution, type D personality, sitting in one place for more than 2 hours. Sitting is akin to smoking. So if you want to do that, I think we should do work on the sitting part also. Periodontitis, hypercoagulable state, frailty, CKD and high heart rate. All these are risk factors and one can work on them to achieve primary prevention. Non-compliance of medication. Somebody is a diabetic, doesn't take medicines well. Hypertensive doesn't take medicine. He's non-compliant to it. Then his risk is very high actually. And this is pigmented knuckles giving high B12 level. He's a rich man, golden rings in his fingers. But obviously he's purely vegetarian and B12 deficient. Vitamin D is there between 11 a.m. and 3 p.m. gives you the vitamin D dose, not the early morning. So we should all be aware, and maybe how many of us can go 20 minutes of sunbathing 11 a.m. to 3 p.m.? I don't know. So it's not practical in India. So despite being in a sunny country, we have such vitamin D deficiency. How it contributes, it doesn't matter. My thinking is it's a simple thing to correct. Why is it called vital amine? It has some vascular implication. Correct it. It's easy to correct that way. Pollution is now clearly recognized as one of the factors. In Pune, there is an area called Nulstop, a very busy area. There, all sparrows have disappeared from there. Because I say that the sparrows know that pollution is a problem, but human beings don't know that pollution is a problem. And there have been, this slide is just to show you that there is a lot of research related to pollution. I don't want to read through the slide. Sitting is akin to smoking. Avoid sitting for more than 2 hours in one place. Standing workstations for IT people. And soleus push-ups. Actually, if you can do that, soleus muscle can be used. Even in our clinics, whenever we remember, push up the soleus while sitting, then you are working out the bigger muscle of the body. So it will help you do other things. So sitting is akin to smoking. Even for us as doctors, move around after half an hour. Take a walk, 15 steps takes about 8 seconds. So you can definitely have that much time. Periodontitis, this young man, 36 years old farmer from North Maharashtra, very wiry, hard-working fellow, triple vessel disease, had to go for surgery. Nothing else, no diabetes, no tobacco, nothing, but just periodontitis. There is evidence related to that I just want to skip and go forward. Frailty is definitely something which we must remember now. A typically frail looking man like this has lost all his, shall we say, pad of fat here and starts looking frail. And the biggest part of the frailty is sarcopenia. They lose muscle and that's why they become frail. And then they fall down and they develop microbial infarction, strokes and other. Totally preventable, totally preventable. And you know what's the first step for preventing frailty? Eating a meal every day with the family. This comes from scientific books. It's not my own creation. So all that you have to do is include them in the family. Don't make them a recluse or don't relegate them to one room. I think that will prevent frailty. Avoid large dose of statins in them. You are already a sarcopenic patient. So be practical about these patients. Feed them well. In fact, saturated fat needs to be given to these people. when they are getting frail. Heart rate and mortality in healthy men, you can see that lower is the heart rate, better is the mortality. I don't know how these studies are conducted. Look at this study, Netherlands apparently. Resting and exercise heart rate measured in 5,000 men were suspected to have CVD. Follow-up was 23 years. And we finished this slide in 5 seconds and 10 seconds, but huge research which goes on. But please pay a thought for this. Reduce the heart rate, your own heart rate. And I don't know whether beta blockers reducing heart rate helps the patient or not. But naturally reducing will help. That is by way of meditation, yoga, and other things which have been discussing a lot. Aerobic exercise, yoga, meditation, mind management, and maybe beta blockers are important. Now, primary prevention obviously has cardiovascular health benefits, followed for at least 50 years of age. And there are, clearly it is a better prevention. Somebody undergoes a primary prevention is much better off compared to those who do not follow this. The longer survival, more than 11 years in men and more than 8 years in women, if you give them good primary prevention. Heart healthy diet, lot of controversies related to that. But I want you to read this extra reading in this slide. It was JACC 2017, and this is from the American Heart Association, and it gives very clearly harm, borderline recommended, and add to it Indian masala, and probably you will be giving them good diet for your own patients and for yourself also. It says that plant proteins are the best amongst the proteins. Combination of aerobic and resistance training is required. I'm showing my photograph not because of showing off, but I could only find this one. So it means that you are keeping your muscles intact. Keeping your muscles intact makes a lot of difference to overall health, especially the degenerative diseases which come later. So drugs for primary prevention, secondary prevention, here. Statins, combination of bempedoic acid, ezetimibe. Suppose somebody's LDL levels are 145, 150, and he is a 45-year-old. Then what do? I think you have to reduce that LDL level to below 100. And suppose he is a metabolic syndrome type of a person, then my choice becomes a bempedoic acid because it is sugar neutral. So rather than starting a statin, I would start, if you find bempedoic acid is not powerful enough, add ezetimibe to it. But reduce the LDL and probably you will get the. And my also dream or something is that something like inclisiran would be used for primary prevention. One injection and then it is done if it becomes cheap enough. CKD has to be used for SGLT2 is a must because it prevents CKD. And patients who are adherent to low risk, suppose, look at this. Somebody who is less than 40% medicines and more than 80% medicine, the difference in the CV events is more than 50%. So those who are adherent to your medicines are likely to be better off as compared to cardiovascular events. We are again talking primary prevention. So in fact, non-adherence is considered a new risk factor in the atherosclerotic disease. So that's why this somebody called N.J. Wald came with the hypothesis of polypill. He said that, okay, so many aspirin and other things are ramipril, they're reducing the events so much. Why not combine them? Hypothetically, it will lead to 80% prevention of primary events. So that's why the concept of polypill came into picture. I do that. Like suppose he's a villager, a farmer comes to me. He's hypertensive. Tobacco is his way of life, and he's non-exercise. He's just working in the fields. If I give him 4 drugs, this, that, he's not going to take it. So I still stick to our old polypill, which little inferior in management, but it works for him because it is giving him good amount of primary prevention. Another non-scientific slide, but this is from the WHO. It is a 75 years of follow-up. 4 research teams died during this follow-up because how many research teams will continue for 75 years? And then they say for staying alive, health, length, quality of diet depends on the social circle and connection and secure close relationship. Look at the top. Social connections and secure close relationship matter, not your exercise, not your hypertension treatment, nothing else matters much. So it's not something which you can say non-scientific. It's a huge study. So epidemiological, that's why we feel, okay, it's not very scientific. But that's why I feel WhatsApp group are a great thing. our own old schoolmates. Now we meet after 25 years or 30 years, and we have a gala time throughout the day. So it makes a difference if you have a large social circle, and of course the very close emotional family and friends type of a circle. So the social requirements that are required for primary prevention are increase in physical activity, yoga, meditation, strengthen the tobacco control strategies, improve dietary choices, simplified screening procedures of risk factors, and fixed dose combinations for compliance of medicine. Home BP measurements must be encouraged because it makes a lot of difference in good management of hypertension. So ideal parameters for health and vascular disease are enlisted. I think you know all of them. So secondary prevention importance is well known. It is somebody who has established this thing, atherosclerotic cardiovascular disease. So in 2025, I think total cholesterol has lost its importance. Then HDL has lost its importance. Triglyceride maybe, but it is the star is the LDL. You have to, our own one target is LDL and LDL and LDL. If you aim at that and reduce it to low levels in high risk people, you follow the LAI guidelines maybe, and you will find that you will do justice to your patient. And we know that lowest is the best is where we have come now. Very high risk people less than 30, and most ASCVD less than 70 is what we think of. The chronic coronary syndrome is a terminology which was coined in the European Society, and almost 33% of coronary syndromes are in our own practice now, not acute coronary syndrome. So how are they managed? They are managed by preventing events. Actually, it is nothing but prevention of events, that is secondary prevention. And there are some other trials which also support this kind of conservative management for chronic stable disease. The guidelines are completely different. Suppose somebody has an 80% lesion in the right coronary artery, acute coronary syndrome, no doubt you have to stent it. Chronic coronary syndrome, you may have to wait and treat him on medical treatment. So that's kind of a difference is possible. Because chronic coronary syndrome, if you leave on good medical treatment, there is about 5%, 6% chance of getting an event in 1 year. And if you put one stent, the risk level is also so much. So it's not a great difference except for symptomatic management. So if we look at these ACC-AHA management of stable ischemic heart disease, most of the things are known. So it is said that it is the most preventable disease. One of the most preventable diseases is the cancer which happens because of smoking. So if you don't smoke, you don't get that cancer. But the second most preventable disease is second heart attack. So if you really work on your patients, then you can be a winner by preventing him his hospitalization, expenses, and so many other things. So the COMPASS trial thought that why not in these patients give rivaroxaban instead of the second antiplatelet agent, which was anyway overused. So if you have somebody who has 65 and above, diabetic, ASCVD, polyvascular disease, that means he has coronary disease, carotid disease, peripheral arterial disease, this probably makes a case for rivaroxaban vascular dose 2.5 milligrams twice a day, but it has not appeared in the guidelines. So I would leave to that only this kind of a subset where one could use, but otherwise I will wait for some more time. So I feel monoclonal antibodies and other things have to be used because there is a reduction of almost 60% reduction in LDL on top of a statin therapy. Such a whopping reduction is not possible with drugs which can cause side effects, and the frequency of inclisiran is also very little. So slowly the use of these things will go on as time goes by. The official winner of Not My Job contest, this man was given a job of painting the side of the road. And because this tree bark was here, he painted around it, saying that it's not my job. So treating coronary artery disease is like that. If you don't prevent, you will get an official winner for this kind of a job. This whole therapy thought process started by Dean Ornish. If you read the book, it is highly unscientific to start with, but the principle is correct. Good lifestyle, it can prevent, is what it says. And then it appeared in the American Journal of Medicine way back in 1998 about non-invasive management and reversal. So I'll just read one drink and just only 10 seconds to go. So if you have what is reversal of coronary artery disease, if there is no stenosis, hypothetically blood comes here and comes out of 5 lines. 50% stenosis, no change in flow. 75% change, no stenosis. But at a critical juncture from 75 to 80, suddenly there is flow limitation, incidences, angina and other things. So if you reverse from 80 to 75, suddenly you will get more flow. Your stress thalliums will be normal. So this kind of a reversal, mini reversal, makes a huge difference because the flow dynamics is such that flow is dependent on the fourth power of the diameter. So if you increase the diameter a little bit, it will help a lot. I think I'll go to the last slide now. Okay, from birth to natural death, if you draw a line, a triple vessel disease leads to premature death, but a good maybe bypass surgery brings him back. A double vessel disease leading to premature death, a good angioplasty does that. Let the interventionalist and cardiac surgeon do this part. It is a major change in a small community. But what we have to do as clinicians is prevention and prevention and prevention. You follow the principles, patient will go to his natural death without undergoing any other things. Thank you.